I expect that you would have had a PDF by now, and I think we have some time in the end for questions if there are going to be any. But I would like to go through the lesson anyway, just to make sure that you are going to be well versed when it comes to schizophrenia spectrum disorders. So you should be seeing the screen by now, and well, I don't know if we're supposed to be recording, but if it's all right with everyone, we'll go ahead and start. So schizophrenia spectrum disorders are going to be very, very important to us when it comes to managing patients in psychiatry. It is one of the most common disorders that we frequently encounter and that you will also encounter in clinical practice, even in primary care. So the lecture objectives for today are going to be to review the clinical presentation of schizophrenia and other psychotic disorders, to cite the DSM-5 criteria for schizophrenia spectrum disorders. This is going to be unavoidable in your year level, and to discuss the pathophysiology behind them. I'd like to present these in the form of questions. And essentially, we start off, of course, with what are schizophrenia spectrum disorders. Historically, the earliest records of psychosis are going to be found in the Vedas of the ancient Hindus, that's in India, and the Ebers Papyrus, that's in Egypt. And both of them will have early descriptions that will include agitation, hearing voices, thought disturbances, and poor self-care. And later on, we'll see that these continue to be present currently among people with schizophrenia. And throughout Western Europe, throughout the medieval and Renaissance periods, these symptoms were actually just clustered under a general condition of madness, and attributed to supernatural causes like demonic possession, the devil, or witchcraft. But clinically, scientifically, as we know science to be now, the full description was first presented by Kraepelin in 1887. Kraepelin had the distinction of really trying to separate madness categories, and he came up with two. The first was dementia precox, that's schizophrenia as we know it now, and the second was manic depression. Now we call it bipolar disorder. The formal term of schizophrenia is rather old, and it was introduced by Bloiler in the 1900s. And the root words for these literally will mean a split mind, a schism of the mind. Now, schizophrenia is primarily characterized by the following. The first and the most important is a disturbed thought, content, and process. So schizophrenia is going to be primarily a thought disorder, in contrast, say, for example, to depression, which is going to be a mood disorder, or personality disorders, clearly a problem with personality and behavior. Well, schizophrenia is primarily a thought disorder. Because of the disturbed thought content and process, it can lead to disorganized behavior and at times even a lack of emotional expression. When we say schizophrenia spectrum disorders, the flagship disorder is going to be schizophrenia, but we also have the following in the spectrum, and this includes schizophreniform disorder, brief psychotic disorder, schizoaffective disorder, delusional disorder, and substance medication-induced psychotic disorder. This is something that is later on we'll see is easier to remember if we contrast it to the flagship disorder of schizophrenia. And we'll start by talking about schizophrenia. It has a lifetime prevalence of technically less than 1%, but easier for you guys to remember 1%. Approximately, therefore, 1 million Filipinos suffer from schizophrenia. And this is actually backed up by comparing it to our census of 116 million people. The male to female ratio is 1.4:1. More men will be diagnosed with schizophrenia, and they are diagnosed earlier compared to women. The median age of diagnosis is 25, so it is going to be something that can be present at a rather young age. And because of that, a lot of people do experience severe functional impairment. It impacts them for the rest of their life. Aside from the functional impairment, we know that schizophrenia is also associated with a decreased life expectancy in general of around 15 years. So if the life expectancy of a Filipino is 70 years old, people with schizophrenia, their average life expectancies would be around 55. There is comorbid substance use in 50% of people with schizophrenia, although this includes nicotine use. This does not mean illicit substance use. A lot of people with schizophrenia do smoke because the nicotine decreases the voices that they hear, but it is something that contributes to their decreased life expectancy. There's a 12 times increased likelihood of suicide, and a couple of hypotheses for those include really just the functional burden of having schizophrenia and the depression that this engenders. But also some people posit that it could be because of the auditory hallucinations. So hearing voices telling them to end their lives. People with schizophrenia have a higher than usual risk for cardiovascular and cerebrovascular diseases, diabetes mellitus, COPD from the smoking, and also infectious diseases from the poor self-care. Now, when we look at the schizophrenia spectrum disorders, it would be helpful for you to categorize the features in three, and these are general clusters. There are going to be the positive symptoms, the negative symptoms, and the disorganized symptoms. We want to understand positive symptoms as being comprised by excesses or distortions, meaning there is going to be the presence of something that should not be there. So the presence of abnormal behavior or the presence of symptoms that are not present in an ordinary person without schizophrenia. And these are going to be delusions, fixed false beliefs, and hallucinations, sensory experiences in the absence of any stimuli. The second cluster will be negative symptoms, and negative symptoms consist of behavioral deficits, meaning the absence of something that should be there in people without schizophrenia, and or the absence of normal behavior. You will note that negative symptoms all start with an A, except flat affect, because we can't call it A affect, but these include avolition, alogia, anhedonia, asociality, and flat affect. The prefix A meaning without. So without will, without the appropriate amount of words when they talk, without pleasure, without social interactions or the drive for social interactions, and a very flat demonstration of mood, we call that affect. Finally, there are the disorganized symptoms, and this includes disorganized speech and disorganized behavior. We'll go through them in some more detail as time allows. For positive symptoms, I mentioned there were two. These are not normally present in people without psychosis or schizophrenia. Delusions are fixed, false beliefs not in accordance with logic or culture. So, for example, a person believing that aliens are going to be landing in their backyard and maybe digging up tons and tons and tons of gold and potentially killing them in the process, despite people convincing them that there are no aliens and there's no gold in the backyard and nobody is going to kill them. That's an example of a delusion of persecution. Someone is out to get you. Please note that delusions are not in accordance with culture as well. So if I said that I believed in this random being whose body I eat, every Sunday, because there is a representative of this being who turns this bread into his body, then that's religion. That's not a delusion. That's the Catholic religion in the practice of hearing Holy Mass. So we don't consider that a delusion. So keep that in mind. They should not be in accordance with any reasonable logic or culture. There are 5 types of delusions. Erotomanic is the belief that someone really famous, really well known, is desperately in love with you, despite evidence to the contrary. Grandiose delusions are when a person feels that he has superpowers or he has an indiscriminate amount of riches or wealth or positions that he doesn't really. Persecutory, as I mentioned earlier, is the belief that someone is out to get them or persecute them. Somatic delusions are relatively rare, and this will entail the delusion that something is wrong with their body, usually not in just an anxious level, but like my insides are rotting away slowly, or there are aliens nibbling at my heart, something like that. And finally, the delusions of jealousy are when you really believe that your partner is cheating on you, despite evidence to the contrary. Of all of these, persecutory delusions are the most common in schizophrenia spectrum disorders, although we do see grandiose delusions in bipolar disorder. For schizophrenia or for psychosis, 50 to 70% of people can experience persecutory delusions. It is a cardinal symptom of schizophrenia. The second positive symptom is hallucinations. As mentioned earlier, these are sensory experiences in the absence of any relevant stimulation from the environment. And magic, for example, when you watch a magic show, there's a rabbit being pulled out of the hat. That's not a hallucination because there was that trick in the environment that the magician was doing. That we call an illusion or a misperception, but there was a stimulus. When we say hallucinations, there there is a sensory experience, meaning any of your 5 senses could be involved, even if other people can't sense these. So these can be auditory, visual, tactile, olfactory, or gustatory, all your 5 senses, not all at once, very rare. But examples of auditory hallucinations could be hearing voices. Visual hallucinations could be seeing people and there's no people around, seeing dwarves and there's really nothing around, seeing animals even, and there's none around. Tactile hallucinations could involve the feeling of something crawling in your skin or the presence of weight somewhere in your body, but it's really not there. Olfactory, meaning smelling something that isn't there, and gustatory, meaning tasting something that other people can't taste, really. Like you could say that the water tastes like blood, or even if you're not eating something, there's this taste that's very distinct, and there's no sensory stimulus that could actually account for that. Of these, the most common will be auditory hallucinations, and they will affect 60 to 80% of patients with schizophrenia. So this is a classic presentation of people with psychosis having persecutory delusions and auditory hallucinations. And this is one example of it. This comes from a very old movie, Dr. Nash, who has since then passed away. He said, the staff at my university, the Massachusetts Institute of Technology, and later all of Boston, they were behaving strangely towards me. I started to see crypto communists everywhere. I started to think I was a man of great religious importance and to hear voices all the time. I began to hear something like telephone calls in my head from people opposed to my ideas. Delirium was like a dream from which I seemed never to awake. We will note that the statements, apologies, the statements underscored in blue are going to be examples of delusions, and those underscored by red are examples of auditory hallucinations. When Dr. Nash felt like other people were behaving strangely and they were crypto communists. These can be linked to delusions of persecution, because crypto communists were perceived to be persecutory then. When he starts to think he's a man of great religious importance, this is a grandiose delusion. And hearing voices all the time, even when there are none, that's an example of auditory hallucinations. Now, this is another example from a patient with schizophrenia. And it starts with, I am decoded through an implantable multi-component nanostructure device, which transmits acoustic around me and the signal of the brainstem. Plus, it can communicate back into my implant. One device was implanted in my left inner ear near the pons in 1966. This device is not energized by batteries. I was studied by the wave of the signal compared to what I was saying. I was decoded in 1973. Ralph replied back into my implant in relation to what I was thinking. Ralph and Diane reply to my implant whenever they wish, which is almost every waking minute. No strategy, no privacy of my mind, also not treated properly by Diane and Ralph. This is a statement that came from the 1980s onwards, I think, before the 1980s. And we'll see here that it's a great example of how delusions of persecution and auditory hallucinations can actually interact. The delusion is that he has a nanostructure device which studies him implanted in the brainstem and allows the hallucinations to come in. So it provides the delusion of persecution, provides an explanation for this person for him to be able to reason why he's hearing voices. And these voices are also persecutory in nature. The person is not treated properly by Diane and Ralph, and he doesn't get any peace of mind. So delusions and hallucinations can certainly interact together in psychosis. The next cluster that we mentioned earlier would be the negative symptoms. And again, most of them start with A. Avolition, meaning the lack of motivation or the lack of will. Alogia is a significant reduction in the amount of speech, and hedonia is a lessening of the ability to experience pleasure. Asociality is social isolation, and flat affect is a lack of outward expression of emotion. Most of the time, these do not come singularly, they come in clusters. So a patient with schizophrenia often is found inside his room, just not interacting with anyone, not wishing to do anything, not experiencing pleasure in anything, not looking forward to anything. Very much isolated person. And this is one of the most difficult to treat clusters of symptoms for schizophrenia. Finally, we have disorganized symptoms, and disorganized symptoms are clustered into disorganized thought or speech. When you talk to a patient with disorganized speech, you will know that it comes from the inability of the person to organize their thoughts. When we talk, it's a reflection of how we think, and disorganized speech reflects the disorganization of the thinking process of a person with schizophrenia. There are a variety of examples. For example, word salad, where the speech is totally incoherent. You can't make sense at all of what the person is saying. It's just a random jumble of words. There's neologisms, like creating new words where they used to be none. For example, a term head sock could mean a hat. So really making up new terms that are not familiar to others. Echolalia is pretty much parroting back or repeating what others say. And tangentiality is the shift from one thought to another without obvious logical connections. I believe that you may have discussed some of these in the lecture on MSE, mental status examination. And these are the ones that traditionally can be found in people with schizophrenia. Disorganized behavior is manifested by a severe failure to perform activities of daily living, including self-care. There are going to be bizarre actions like collecting rubbish or wandering aimlessly. And we see here in the photo If you may be familiar, the picture of Zorro from before the pandemic, and he is very well known around the UP campus to just be wandering around, sometimes directing traffic, sometimes just walking around, sometimes just talking to themselves. Sometimes disorganized behavior can come with incongruent emotions. So walking around and being really, really upset, really angry, even though there's nothing to be angry about. Laughing when someone says something that is really, really sad. So this also tells us that there's a good deal of disorganization in the brain. Finally, we have catatonia, which is quite rare now with the advent of the novel antipsychotics, but catatonia involves a spectrum of motor abnormalities from continuous movement, nonstop almost movement, to catatonic immobility, which is, as we see here, maintaining unusual postures for a prolonged period of time. Now, they can also manifest with waxy flexibility, where the patient's limbs can be manipulated and posed by another person, and they will stay that way. An example here, I think you can find in one of Robin Williams' movies. It's called Awakenings, and it was based on a book by Oliver Sacks. So that's a good example of catatonia, particularly waxy flexibility. Now, how knowing what roughly psychosis presents like or schizophrenia presents like, how do we formally diagnose them? We, of course, follow the DSM-5, and DSM-5 criteria for schizophrenia will state that the two or more of the following, each present for a significant period of time during a 1-month period, must be present. And at least one of these would include delusions, hallucinations, or disorganized speech. This means that if you only have catatonic behavior and negative symptoms, you can't be diagnosed with schizophrenia. It has to include one of delusions, hallucinations, or disorganized speech. So actually, you could have disorganized speech and disorganized behavior that could qualify as schizophrenia, or purely delusions and hallucinations, or delusions and negative symptoms. They must include one of delusions, hallucinations, and disorganized speech. The level of functioning must be markedly below the level prior to onset, and continuous signs of the disturbance must be present for at least 6 months. So maybe the person here to be diagnosed with schizophrenia could have delusions for the last 5 months, and this month he develops hallucinations as an additional symptom. If both delusions and hallucinations then last for another month, that meets the 6-month criterion, and the active symptom period for the 1 month as stated in criterion A. I hope that you can keep in mind that we cannot diagnose schizophrenia in 1 month, that there must be continuous signs of disturbances for at least 6 months for the diagnosis to be made. Finally, it's not attributable to other disorders with psychotic features or the effects of a substance. We'll see that the core symptoms are very similar to the ICD-11, but we normally will still follow the DSM-5 criteria. What about the other schizophrenia spectrum disorders? We have schizophreniform and brief psychotic disorders. These have similar diagnostic criteria as schizophrenia, but the difference is the duration of symptoms. Schizophrenia must be, the symptoms must be present for 6 months. For schizophreniform disorder, it's 1 month to 6 months. So if they don't meet the 6-month cutoff for schizophrenia, but they've had symptoms for more than 1 month, then we call it a schizophreniform disorder. A vast majority, 60 to 80%, will eventually receive the diagnosis of schizophrenia later on in life. Brief psychotic disorder is even briefer, and this is also similar to schizophrenia, but the duration of symptoms are less than 1 month. Half of patients will recover, and never experience a recurrence of the symptoms. That's great for them. But the other half will also eventually go ahead and meet the diagnosis or schizophrenia later in their life. Another schizophrenia spectrum disorder is schizoaffective disorder, and this is pretty much just a combination of a mood disorder, affective, and schizophrenia. For this disorder to be diagnosed, there must be an uninterrupted period of illness occurring during which a major depressive episode, a manic episode, or a mixed episode occurs with symptoms that meet criterion A of schizophrenia. So you will see, therefore, that usually we require still that the time will be 6 months in duration. This is a typical pattern of schizoaffective disorder. But during the same period of illness, delusions and hallucinations must occur for at least 2 weeks without prominent mood symptoms. That is what makes it a schizophrenia spectrum disorder. There must be at least 2 weeks where no mood symptoms are present, just purely psychosis. And for the rest of the time, majority of the time, the mood episode is also there. So you'll see that presented in a graphical format to the right-hand part of your screen. The gray zone represents the presence of psychosis, which is longer compared to the mood episode, but the mood episode is very much prominent and present majority of the time. Another schizophrenia spectrum disorder is delusional disorder, and as the name suggests, this is a disorder that manifests primarily with just delusions. And the duration required is at least 1 month or more. The criterion for schizophrenia has never been met. So this is really just primarily delusions. If there are hallucinations, they're not prominent or they are related to the delusional theme. Aside from how the delusions impact the person, the functioning must not be markedly impaired. So people with delusional disorder can still go ahead and work. They're not obviously bizarre or odd, and there should be no significant manic or major episodes. These should be shorter compared to the delusional periods. And again, they're not attributable to another substance, another medical condition, or another psychiatric condition. Remember that there were 5 types of delusions, and based on these 5 types of delusions, we can subtype the delusional disorder. There is the persecutory subtype, the erotomanic subtype, also known as the Clerenbol syndrome, the subtype of jealousy or Othello syndrome, the subtype of somatic delusions, which predominantly consist of malfunctioning organs, and grandiose delusions. If there are multiple delusions or delusional themes, we can state that it is mixed or unspecified. Finally, we have substance or medication-induced psychotic disorder. I think it's important that we acknowledge this because it is something that we always have to rule out whenever considering schizophrenia, that it might be secondary to a substance or a medication. These are the DSM criteria. There should be either delusions or hallucinations. There should be evidence that these symptoms develop during or soon after substance intoxication or withdrawal or after an exposure to a medication. Even medications can cause psychosis in vulnerable people. And these include IV steroids, for example. For substances, the most common include cannabis, methamphetamine, and cocaine. So you must be able to logically prove that the medication is capable of producing delusions and hallucinations. There's literature that suggests these, and the disturbance is not better explained by a pre-existing psychotic disorder or a psychotic disorder that persists even after you withdraw the substance for a long period of time. The disturbance will not occur during the course of a delirium, and it should cause clinically significant distress to a person. All of the schizophrenia spectrum disorders, part of the DSM-5 criteria is that it should cause distress and dysfunction. Now, having gone through the DSM criteria, we want to understand what causes schizophrenia spectrum disorders in general. And we have the biopsychosocial approach here as well for the etiology. We have the biological vulnerability, psychological stress, and social factors. We'll try to go through all of them. First, it is very clear to us that the vulnerability to developing schizophrenia is heritable. You'll see in the diagram that relatives of people with schizophrenia are at increased risk. You will see that in the top hand part of the slide that monozygotic twins have the highest risk for developing schizophrenia. So the risk increases as the relationship becomes closer. But genetic factors will not suffice by themselves. There will be environmental factors that will interact with genetic predispositions to disrupt normal brain development and function eventually. A person is not born with schizophrenia. This develops later on in time, as many of our multifactorial diseases do. The brain structure and function can help us understand why there are disorganized symptoms of schizophrenia as well as negative symptoms. Developmentally, as uh, children grow, of course, there is a phenomenon called pruning to remove excess synaptic connections. In a person with schizophrenia, it's believed that the pruning occurs significantly more than what is necessary. And therefore, there is less synaptic connections to begin with. Now, this is worsened by the neuronal death caused by the neurotoxicity itself of the disease. And this is going to be demonstrated here with the brain imaging to the right-hand part of the slide. The image of the brain to your left is a person without schizophrenia. So you can see very narrow ventricles here in the middle, the butterfly shape area in black. And the one to the right is a person with schizophrenia. So you'll note that the ventricles are significantly enlarged and there's much, much less gray matter. There's much less brain volume. These are consistently also demonstrated by post-mortem studies and really imply a loss of a lot of brain cells. And it is correlated with impaired performance on neuropsychological tests, poor adjustment, poor response to stress, and poor response to medications because there's less of the synapses for the medications to work on. How do medications for schizophrenia work? They work by balancing the dopamine in the brain. Of course, at this level, we'll not be talking about the antipsychotics, but it is crucial to understand that dopamine is still the key to understanding the pathophysiology neurochemically of schizophrenia. An early dopamine hypothesis posited that people with schizophrenia just have a high level of dopamine all over the brain. And they posited this because of the phenomenon of amphetamine psychosis. People taking amphetamine stimulants like cocaine or methamphetamine would present with significant positive symptoms, including delusions and hallucinations. We still see that until now. But later on, this hypothesis was modified to um, a localized imbalance of dopamine function. We now know that there are 4 dopamine tracts in the brain. This includes the mesolimbic, mesocortical, tuberoinfundibular, and nigrostriatal. What is important at our level will be the mesocortical and the mesolimbic pathways. You see that in the picture as yellow and green. In the mesolimbic pathway, there is still going to be a significant increase in dopamine, and this is the one that accounts for the positive symptoms of schizophrenia, the delusions and the hallucinations. And it's easier for us to remember this because positive symptoms mean high dopamine levels in the mesolimbic area of the brain. However, negative symptoms are associated with significantly less dopamine, but that's going to be in the mesocortical area of the brain, so prefrontal cortex. And this hypoactivity leads to the asociality, avolition, flat affect, alogia, and anhedonia. So You can imagine it a little bit like a seesaw, with the high dopamine levels correlated to positive symptoms in the mesolimbic pathway, and the low levels in the mesocortical pathway being linked to negative symptoms of schizophrenia. And later on, next year, you will see how medications try to address these. When it comes to psychological factors, we know that stressors can contribute to the development of schizophrenia, but also that people with a genetic vulnerability with schizophrenia can react to stressors more. They're really more sensitive to stressors, and they can be significantly disturbed by environmental stressors. They can react more negatively to these. And this is something that has been demonstrated to be genetic, the reaction to stress. Family studies also implicate abnormal communication patterns within the families of people with schizophrenia. And one of the most supported hypotheses here is going to be the presence of high expressed emotions in the families of people with schizophrenia. What's expressed emotion? It's not just expressing, hey, I love you so much, I'm so happy. It is rather a psychological construct that's measured by the level of criticism, expressions of hostility, and emotional over-involvement of parents or family members with the patient. So you imagine a family that is super over involved with you, but also in a very, very negative way, and they will not hesitate to let you know every single moment of every day. That's high expressed emotion. And high EE families were associated with higher relapse rates for their patients, with a relapse rate of 58% for high EE families, compared to a relapse rate of 10% for low EE families. So the environment that they live in continues to matter. And this is further highlighted by the social factors. One of the things that we continue to see is that people with schizophrenia tend to belong to urbanized, low socioeconomic areas. And there have been several hypotheses that have been presented to explain these. The first being the social causation or the sociogenic hypothesis. This pretty much states that belonging to a low socioeconomic status will increase the risk for schizophrenia. And that's because of a variety of mediating factors, such as limited educational opportunities, limited healthcare access, more obstetric complications, poor maternal nutrition, and just a generally more hostile environment. So in the sociogenic or social causation hypothesis, it's the social economic status that furthers the risk for schizophrenia. In the contrary, the social selection or the downward drift hypothesis states that the presence of schizophrenia causes people to not do as well as they could have done if they hadn't had schizophrenia. So the schizophrenia, which occurs early in life, in itself will lead a patient not to develop economically as well as other people without schizophrenia. So people with schizophrenia tend to drift lower in the social strata because of their functional impairment. Of course, both of these are likely to be correct. There could be a belonging to a lower socioeconomic status, developing schizophrenia, and then being unable to rise up out of that lower socioeconomic status. The last question is really how do we treat schizophrenia spectrum disorders? And here we spoke about, I mentioned to you earlier, medications. We will not dive into that today. That's for next year, for you at least. But I want you to understand that treatment for schizophrenia can be difficult. It usually entails a combination of short-term hospital stays, a lot of outpatient consultations even after the hospital stay, antipsychotic medications, which are crucial for the management of schizophrenia, and psychosocial treatment, which supports the overall treatment plan. The problem with treatment is the lack of insight that the patient has. Imagine that you're hearing all these voices that seem very real to you. You really believe that there's gold in your backyard. You really think that doctors are out to get you or someone is out to kill you. And then that same doctor gives you medication. So you don't believe that you are ill. And a fantastic way to look at it is a very old movie called The Beautiful Mind. You will see that it's really difficult for people with schizophrenia to accept that their reality is not our reality and to adjust accordingly. So usually they will stop their medications. Adherence rates are half for antipsychotic medications. And when we stop medications, patients tend to relapse. Even when family members want their want their relatives to get better, usually it entails a lot of pushing, a lot of prodding, a lot of arguments. And even doctors may have a difficult time getting patients to stay on track when it comes to treatment. Because of this, the course and prognosis of people with schizophrenia is not very good. It's quite poor. We look at the typical course of a patient with schizophrenia in this slide. It starts with a prodromal phase, which is kind of like beginning symptoms with marked decrease in functions, maybe staying in a room for longer periods of time, not wanting to interact with others, beginning hallucinations, and a marked difference in behavior. This is followed by the acute phase where clear psychotic symptoms emerge. There's now those delusions of persecution, very loud auditory hallucinations, and more clearly disorganized behavior. Ideally, the patient should get into treatment. This is the phase where they are brought into treatment because the relatives recognize that there's something clearly wrong with the behavior of their relative. And with adequate treatment, the recuperative or the recovery phase follows, and this can take months to years. There can be that improvement as hope of the positive symptoms, followed by the negative symptoms. Normally, the positive symptoms will improve first, followed by the negative symptoms. And finally, the residual phase, where symptoms could still remain and impaired functioning could persist. The first 5 years after the initial onset of symptoms often determine the overall course of illness. So we really want to promote early intervention. Relapses are the rule rather than the exception. 80% of people will experience at least one relapse within 5 years of their first episode. And many patients have problems returning to previous levels of functioning, and they could remain symptomatic for many, many years despite treatment. Now, we believe that schizophrenia is significantly very much a brain disorder. And we have all those data that I just presented to you to be able to back that up as well. So this is a summary slide for the diagnosis of schizophrenia spectrum disorders. I know that there are quite a few, but just to help, brief psychotic, schizophreniform, and schizophrenia, all of them will have the following symptoms in common: delusions, hallucinations, negative symptoms, disorganized speech, and disorganized behavior. The major difference is that brief psychotic disorder is the shortest, lasting for 1 day to less than a month, 29 days. Schizophreniform disorder will last from 1 month to less than 6 months. And for schizophrenia, the symptoms must last for at least 6 months, 1 month of which must be active phase symptoms. For schizoaffective disorder, the criteria for schizophrenia and a mood disorder are met for more than 6 months. For delusional disorder, there's the presence of, that should be delusions, the presence of delusions for more than 1 month. And finally, for substance or medication-induced psychotic disorder, there should be a clear association between prior substance use and the development of psychotic symptoms. Your book will contain the full list of the DSM-5 TR criteria for schizophrenia spectrum disorders, and I will strongly invite you to read this chapter. This ends the presentation and gives us time for questions, should you have any. So thank you very much for your attention. I know I talk quite fast, but it's to really save time for questions for you. So we have those 15 minutes, I think. That box. I'm not sure how this works. Should we hang out here until 11, or should we like have a timer as to when we'll be accepting questions? Maybe we'll wait 2 more minutes so that it's 10:50. Well, it's 10:48 now in my clock. So by the time that it's 10:50 and there's still no questions, then we maybe can go. I think we just have 30 seconds to go. So, oh, now it's 10:50, but I wanted to thank you for your attention. I hope that you were listening. But for those who are continuing to listen, for your exam, all of the questions will be coming from the presentation today. And you'll find in the PDF, hopefully you can see the notes, the speaker's notes there. That's for you to more fully understand the slides. I will still recommend that we continue to check back on your book that's called Kaplan and Sodak, Synopsis of Psychiatry, and read the chapter if you can. Please try to. But if you can't, then the questions will just be coming from this presentation. So thank you very much for your attention again. And I don't see any questions. So I think we will have a shortened session for today. And good luck in your test. Thank you. Bye.
Thank you po,
Thank
Doc.
you.
Thank you po.